Good morning, everyone, and thank you for joining our session. And again, we definitely want it to be interactive, a discussion of a small group of colleagues. So, and I think this is a great opportunity to do that. My name is McLaughlin-Davis, and I am a clinical nurse specialist, but really my role for probably close to 30 years has been a case manager. So I'm going to talk a little bit about what that historical perspective has been for a case manager all this time. I was certified as a case manager through CCMC in 1993, so I actually took the first exam they ever introduced. I'm very happy to tell you that I work for the Cleveland Clinic Health System in Cleveland, Ohio, based in Cleveland, Ohio. And I've been there for, this year it'll be 25 years. So first half of my career was other areas of case management, healthcare, and the second half of my career has been with the clinic. And a little bit about the clinic is their mission is to care for the sick, investigate their problems, and educate all those who serve the sick. Currently, we have regional hospitals throughout northern and central Ohio. We also have family health centers, health and wellness centers. We have hospitals in Florida, we have a health center in Nevada, and then we have a hospital in Abu Dhabi. We're building one in London, and we have a health center in Toronto. So, and there may be some that I'm not aware of, as we know how everything is just moving targets. We have 51,500 caregivers in our system. We have over 7 million total visits, 220,000 hospital admissions, 3,600 physicians and scientists, and close to 2,000 residents and fellows. So that's just a little bit about the clinic, and they are very dedicated to care coordination. And like I said, for 25 years, I have been serving in their case management department. So I will turn it over to Julianna.
All right, and I'm going to give a little bit different perspective today. I'm Julianne Salette, and I work with the Carle Health System. I've been with Carle, believe it or not, it'll be 30 years for me, coming at 30, yes, up in July. And I've worked in our organization in so many different roles. I started as a secretary, worked as a tech, nurse, got into a lot of quality along the way, and pick any little nook and cranny. I've probably had my hands in it over the years. And have been very blessed, over time. About 3 years ago, I was given the fantastic opportunity to really take truly care outside of our walls and work with underserved populations in very vastly different ways that, frankly, we haven't been able to move the needle on. And all of us in this room have all the accolades that we can talk about because we all do really good things. But we also have areas of improvement ongoing, and that's never going to end. And we're always looking at ways that how can we disrupt ourselves a little bit and do things a little bit better. We are a vertically integrated health system. We have about 7,000 employees between our 3 hospitals, our physician group, our health plan. We're the only health system left in Illinois that has a health plan. And we have the world's first engineering-based medical school. It's privately run, based off of Carle, and it's a partnership with the U of I. So providers come out of that with an engineering degree, do a lot of research, a lot of innovation along the way, of course, as well as their medical practice, degrees as well. So I'm here today to really talk about, just a totally different slant and what is coordination and what does it look like when you truly are outside of your walls. I know we talk about that sometimes through telephonic case management and other types of venues, but we really are those boots on the ground that are out there, and how are we working with our community and truly leveraging our resources very, very differently with our community partners. Oh, thank you.
Okay, off the bat, does anyone have any questions, any sort of experiences or learnings they'd like to share about some of the work, the care coordination work that they've been doing in their own organizations? If not, well, we can start to turn it over to the panelists to get going. I know you were interested, your comment about community partnerships I think would be a great way to sort of kick off our conversation. How have you been exploring how that works? I mean, we've been talking a lot about that the last couple of days. What types of organizations are you working with, and how do you integrate the work they're doing with the work that your own care teams are doing?
Yeah, absolutely. For us, when you're working with very complicated, underserved populations, which truly could be anywhere from poverty, and that's how we started. How do we, what's our lane? What's our obligation to our community as far as poverty reduction? It's very complicated. We're not those city builders, we aren't our own rights, we're not educators, but the one thing that we knew that we could do, and anything that we read, and I will tell you, I read over 1,200 pieces of literature trying to, see what actually works for poverty reduction. And when we looked out there, it wasn't rocket science, but it was very difficult to achieve, and we couldn't do it alone. Very complicated, and you guys are all, you know social determinants very, very well and the influence that it has. But everything we got our hands on always kept coming back to early life interventions. Your best bet for long-term population health and prosperity, it does not matter the science that you look into, it is going back to early life interventions. It's developing a very tight pipeline of support, and it's not just healthcare, it's education. Out of the gate, way back prenatally before pregnancy and all the way up until workforce, which is incredibly important. It's working with an entire family. We were really good at, as a community, focusing on children, but then children go home and the clock resets itself every single day. And there's nothing more influential to anybody's health than that family dynamic, as good or bad as it may be out there. And it was also then, making sure that where people were, they had a resource-rich environment. And when we went into disparate neighborhoods in our community, the first thing they said to us is, hey, Carle, you're not here. There's no grocery stores here. There's nothing here. I mean, a huge long list. The city's not getting flooding under control to whatever. And so, but the one thing that was in, these areas in every neighborhood was a school building. And one thing that we read on poverty reduction too that worked, didn't matter the approach, the country, what it may be, it's really having those resource-rich environments so things are in reach of people. Because we can provide transportation all day long, we can call people all day long, it doesn't match how so many people live. So it was important for us to get out into the neighborhoods, work with the school districts who are already on this pathway too, to really turn the schools into a hub of resources. That means healthcare is in there, and that's for the neighborhood, not just the kiddos, mental behavioral health, dental being provided. You've got your food banks that are in there. We bring our mobile units there, and you just huge long list, but turning that into a hub. And hey, the community college, come over and teach, your adult education, because ultimately people need employment, to be self-sufficient along the way. So we ended up with our community partners being the school districts, ended up being the municipalities, of course, always your United Ways or a entity that's in your community. It was working with the University of Illinois, working with Parkland College, working with the Housing Authority, working with our Regional Planning Commission. And then, of course, on Tier 2, we work with 50 to 60 different agencies on any given day, but none of us could do this alone, and we had to leverage our resources very differently to be successful.
Has anyone had success partnering with schools and have any learnings of their own that they'd like to talk about? Okay, come on back. I didn't go running this morning, actually, so I don't mind the walk.
I'm Tricia Baird. I'm the Vice President of Care Management and Value for Spectrum Health. We're a 13-hospital system in West Michigan. And recently, 9 months ago, in response to our community health needs assessment, we used a virtual platform to provide licensed masters in social work support to schools in a school psychotherapy intervention that allowed the school nurses to escalate to an LMSW. That has gone very well, and we are now putting 6 more FTEs in one of our regional spaces to provide for a community that is very troubled without a sense of resource backup. That has gone very well in a school to municipality conversation, and the metro, more urban area is now evaluating that offering in parallel. So easy for us, difficult for them, and a pretty simple resource lift from a health system perspective that's been very appreciated by our school community.
I'll add to that. One thing that we also found is that the schools were also working on healthcare and plans of care and putting social teams around. While we were putting social teams, wraparound supports, all this every time someone would hit our doors, or they would go to this entity and the same thing would happen. And so one thing that we did, and it was an eye-opener for us, but it was to put bi-directional consent forms in place, which enabled us to have very open discussions back and forth. You know, just, of course, families had to consent to it, but now that we're working on those same plans of care and we're able to share information, and of course there's some that's still protected out there, but it opened up the doors for us to work with agencies in our community that are non-healthcare in very vastly different ways as well. So I would encourage that, and the schools have been one of our best partners to work with in so many different levels.
My name is Sybil Huggins. I work for Atrium Health in Charlotte, North Carolina. I am really based out in Cleveland County, and we have actually put virtual care into the school system. We have a total of 3 schools that are participating right now, and what happens is the child that feels like they need medical care, they can go to the school nurse and they actually see a physician virtually. And then once that physician diagnoses and maybe calls in a prescription, they contact the parents. The parents doesn't have to leave work. They can pick that prescription up on the way home, and then they're also guaranteed an appointment into the children's clinic within 3 to 7 days, depending on what the child needs. And it's been very successful. We have actually decreased the ED usage by 65% for children within Cleveland County, and we are actually planning on extending it to behavioral health within those 2 school systems, and the plan is as soon as they can get another physician hired to expand it into another neighboring county.
I'll share one more quick thing, Mary,
sure,
because I know you got a boatload of great stuff to share here too.
Everyone does.
I know. I like to just talk all day to you guys in this room, honestly. The one other thing that we did to kind of start that foundation and that pipeline, because we were seeing grants coming and going in our community, which really was the death of coordinated care happening in our community. It was really fragmenting what was happening in our community. So our board did make a 20-year commitment, when we did put a couple of $1 million just within our community to also invest in long-term home visiting, so working with these families all the way up until school. Because those of you that are educators in this room, and I know that there are a couple in here, when you hit that 3rd grade level, and I encourage all of you to look at what's happening in your communities at the 3rd and 4th grade levels for reading and math, that is almost a 100% correlation of what you can anticipate for chronic conditions coming on down the pathway, as well as mental behavioral health, as well as long-term prosperity for those kiddos. So it was important for us to make sure that we could knock it out of the park and make sure that we put everything we could around these families so kids were ready for kindergarten and that life trajectory that they were meant to be on. Very high intensity, anything that you can imagine we're in there coordinating, working with, walking alongside families on. And we've also integrated an educator from our school districts into the homes with us because we have capacity issues in preschools in the community. It's been very successful.
So yeah, I want to turn the tables for Mary just a little bit to hear a little more about specifically the populations you're providing more coordinated care services to, and in particular, what it was you were seeing within those populations that led you to decide to put together a care coordination plan, or first to identify work with those populations and then drill down and start to develop plans for those individuals.
Well, thank you. We, being in a hospital, that's where you do play a lot of guessing games. We've had to do that for a number of years, trying to determine, when you'll ask the sweet little patient who's 70-some years old, and you ask her about her support system, and she'll say, "Oh, my son," and, he checks on me, and, later to come to find that the son lives in Washington State, and she knows she's deceiving you, but the biggest fear for many elders I'm saying this anecdotally, but I feel like I'm confident in my assumption is that they don't want to go to the home, so they, to a nursing home, so they feel they'll do anything to hold on to their independence, which we now see that as such a positive if they can be maintained in their own environment, in their own home. So like so many other hospitals, we have a high-risk scoring system built into our electronic medical record, which is Epic. But we also feel like the boots on the ground, so the case managers, the social workers, the nurses, the physicians, the advanced care providers, some of those patients don't trip that high-risk screen, but we know they're high risk. So we do multidisciplinary rounds on all of our patients. We try to do them at the bedside. Most of our hospitals, we are able to do it. They're relatively quick rounds, but it brings the patient into the plan of care. And like we've heard from our other speakers, and I'm sure you're all realizing that, for years and years, we would give patients great plans. Here's you're diabetic, here's 10 good books you can read, here's a free glucometer. No, we have to really bring the patient in and find out what the patient wants to do. Does the patient understand any of their chronic disease? What's the level of their understanding? And I feel like finally we're starting to peel the layers off the onion to learn what it is. For patients, we can't do that for the 5 minutes that they're in the hospital, but we now have our care teams in our ambulatory care centers. We have care teams in home care. We have care teams in our community partners. So as understanding the patient is in the middle and we're all along the continuum, we are finally starting to help each patient in groups and populations, but really it's one patient at a time, and really giving the attention to the patient when they need it most, listening, and to what the patient is telling us, and understanding. So in the hospital, we start that way with our rounds and identifying who's going to need care coordination.
I would take it even beyond that when we're talking about outside the walls. If any of you, and all of our resources are different, but if you have partners that are actively in people's homes, I will tell you, please concentrate and focus on them a little more, even perhaps. It's been lessons learned for us, whether it be home care, whether it be hospice, whether it be another community agency, because they have windows into how people really live compared to how we see them when we just see a tip of an iceberg when people present themselves to a clinic or a hospital. And if you talk to your own home health agency groups, and there's some of you that are here in this room, and I was over home health for a while, we worked so hard in our hospitals to write these great discharge plans, give them those 20 books, to go home and find out that the caregiver was an 8-year-old child who's now truant from school, was that 77-year-old perhaps who has Alzheimer's, and really was that other person was the caregiver for them. Physicians used to go into the homes many years ago to do visits, and now we just see you when you pop in, to our clinics, our hospitals. Again, there's so much more behind that story, that's happening. And if you have folks that are out in the community, they can help inform the rest of the care team to really make sure those plans of care really do match how people actually live.
Hi, my name's Ann Jesse, and I work for Evolent Health, who partners with individual healthcare systems on delivering care coordination and transition care models. The team that I work with the most closely right now is at Carle Clinic in Roanoke, Virginia, and 100% or nearly 100% of the care delivery by nurses is over the phone. And we have been able to effectively engage patients in self-care management across several programs: transition care, complex care, end-of-life care, and SNF care. There are two schools of thought. you know, you have the nurses and the care team that are face-to-face with the patients and families across all care settings, and then there's the virtual model. And this virtual model that I'm describing is very different than what a payer care management model would be, because we can directly reference the PCPs and specialists and act like we're sitting next to them in the practices, and that's been very effective, and we have very few barriers. What I'd like to hear from the two of you and others in the room is, have you had experience in a virtual care only delivery model, or I think in a perfect world, that virtual model interfaces with the face-to-face models, and that's nirvana?
Well, I can address, we have both. We have the virtual models, so registered nurses call all our patients when they're discharged, and we have a hub that addresses that. However, that's for the it's for the patient that does not appear to be complicated or have needs. So every patient gets a call. However, if the patient is identified as high risk, complex, they will go to the care coordinator with their provider. So if they're in our system, and many of them are, but then many of them are from across the country, so they're not obviously in our system, we will contact the care provider. We will also reach out to them with a phone call from a registered nurse. And it's the registered nurse's responsibility to make sure those transitions occur. So if she doesn't reach the primary care provider's office, she works at it until she actually does talk with a caregiver in that office. We have within our health system, within our ambulatory health system, we have social workers who provide all their care telephonically. So they have a panel of patients and do, work with patients who need referrals to behavioral health. They will do some phone counseling, referrals for community centers. They'll set up transportation. We also have non-licensed providers who do some of the legwork for, the social worker will refer to them to set up the transportation. So we try to use everyone to the top of their licensure to make sure that we're being good stewards of our own resources and trying to make it as efficient as possible. But I agree you can touch so many more people telephonically. At some point, there does need to be a face-to-face, so that hybrid seems to work for us.
It is a hybrid within our system, and it really depends on each community that we may be in. That could be very rural with our rural health network we have with other systems across the state. Sometimes we're providing the telehealth. Sometimes within our own system, we're also working with an outside vendor to do some services such as telemental health as we continue to grow and develop those services. For the underserved populations that we are working with predominantly in person to develop a relationship, I will say is absolutely everything. And every family is different on how they respond to different types of things, and it has to be, once again, a good fit for each individual family that we're working with. But we do have a plethora of different types of tools and resources that we work with. If somebody doesn't speak English, we can't just jump into this or this or this. We have translational support that often will come into the home first with us, and sometimes we have to do that telephonically even as well. But it really is bringing things to people who have life challenges and complexities, and so many people we are realizing far more than probably what we realize and what you realize aren't even hitting our health system, or if they do, it's very episodically. So
I just have a couple questions up here. I'll get to you, but yes, please keep them coming. Appreciate it.
Hi, my name is Rochelle Heflin-Wiley, and I am the manager for transitions of care with Kaiser Permanente, Georgia region. And so, if anyone, I don't know if everyone knows a lot about Kaiser or not, but we are an integrated health model. And so we are able to probably do a little bit more for our members than some others. But what we have is we have a transitions program, and that program is compiled of transition coaches, which are RNs. We have post-discharge outreach coordinators who are also RNs. The transition coaches actually focuses on the high risk for readmission members. We do have a risk stratification predictive model that we use to identify those high-risk members and those low to moderate risk members. So we concentrate on not just the high risk, but those high-risk members, we actually go into the home and hold on to them for 30 days. We actually have them to determine a health goal that they would like to accomplish in a 30-day period, because what we already know is that we tell our patients, do this, 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 and this. That has not worked. So we have to appeal to the patient to determine, hey, what's important to me? So we go in and we work on those health goals that that particular member would like to work on in a 30-day period. If it surpasses the 30 days, we have complex case management where we can pass that patient on off if we need to. We have our physicians that we work very closely with in our ambulatory care setting. We have inpatient case management where our transition coaches are also in the hospital introducing the transition program, saying, hey, I'm going to come to your house when you discharge, and giving them that type of information. We found that that has been very, very successful. Following what we call the Care Transitions Intervention Model by Eric Coleman, it has just been awesome to touch the patients that we need to touch in a timely fashion.
Totally agree, and you're spot on. And we do have a variety of 30-day, but there are some populations that we've made a commitment to at least 2 years being in homes, especially when you're talking about poverty reduction and people in very challenging life circumstances, some up to even 5 years if we're talking about opioid babies, and we haven't hit our 5-year mark, in there yet. But it just depends on what the populations need,
My name is Rachel Tardy, and I'm from Indianapolis. Eskenazi Health is the organization that I represent. My question is actually directed to Mary. There's a lot of great programs that I'm hearing so far, but I wanted to go back to your discussion about your interdisciplinary teams that exist in the inpatient space. You talked about bedside rounding. Can you share some of your insights in terms of how you can do that quickly, especially when you have sustained high census? How do you make sure that you manage that in such a way that's efficient? We want to engage, of course, the patient. We have a ton of members of the care team that should be there. How do you do that and do it efficiently?
Well, thank you for your question. It's very challenging. So you are, we started it, I would say, 5 years ago. So didn't even quite have the momentum that we have now to make the patient the center of care, in this really broad-based way that everyone recognizes, including the government. We just met in small groups with nursing, with therapy, with some physicians. So again, it depends on the hospital. If you're working in a community hospital, chances of you getting a community physician to round with you are slim to none. However, he or she may have an advanced practice nurse that, and many of them do now, that make rounds in the hospital. So we had luck bringing them on the rounds with us and selling the value that you're going to get everything done right then. So in that half hour to 40 minutes, if a patient needs something, the advanced practice nurse is there, she can write the order, and it can just be done. It's not this, the bedside nurse doesn't have to call the physician. So we had to kind of sell that it would be economical. We have not at any of our hospitals, except for the orthopedic floors, been successful in bringing therapies with us. So they, on the orthopedic floors or the the spinal cord injury areas, we will get therapy to do rounds, but otherwise they're spread far too thin. So they give us a written report of their recommendations every morning. Again, if you have an advanced practice provider, physician, nurse, PA, if you have the bedside nurse, you have the case manager, you have a good team that can really make those rounds in 30 minutes and document what needs to be done, then we would also give responsibilities. We'll say, okay, you're going to contact the family. You're going to let the doctor know that this patient is ready for discharge and we can have him home with home care today. So instead of just leaving it up in the air, we would make assignments for the team to accomplish it. We would time ourselves. We actually had a timer, an administrative assistant who would time us and prod us along till we became really proficient at getting in the rooms. Of course, the patient would have a question, so we would always say, I'll be back. So whoever that question was directed to, we would promise them we would come back and talk with them, and we had to keep that promise, of course. So do we do it perfectly? No, but we are committed to it. It has become part of our process, and we don't have nearly the complaints that we did when we initially started. In fact, I don't hear any complaints anymore, to be really honest. I think the value has finally been demonstrated to everyone.
I will share very quickly in our own hospital, it's taken us multiple years to get to where we are. It's not perfect either, but it's evolved over the last 3 years. It helped us tremendously where we had hospitalists, and we have adult and pediatric hospitalists. They were everywhere across our hospitals. And we developed pods. So hospitalists are assigned to very specific areas, as well as the care team, as well as the social work and care coordinators. It's all decentralized that way. So that way every team everywhere in our hospital meets at 10 o'clock every day. That is just a given, 10 o'clock. And then some areas have them twice a day, and a whiteboard, and we engage the patients, or their caregiver in there very carefully, timing, like you said. But it wasn't until we assigned hospitalists, you work in this area, the green area, you're the blue, you're the orange, and the teams know each other. We don't push everybody all across the hospital anymore. The teams really know each other, so it helped.
I'd like to step a little to the side for a minute and bring us back to the Health Tech Act, investing in IT that was supposed to really facilitate and the coordination and communication. I wondered on the ground, how well is it really working for people? Is there really such one system that everyone involved in a patient on any point of the trajectory as proposed originally, the comprehensive electronic care plan that everyone touched and communicated? I wonder what's the experience so far with that, especially settings where you don't have one IT system, one health plan, one health provider. Anyway, I'm just opening up to the audience. The audience, please.
Well, I can just make a quick comment in that's an area where there's a lot of growing pains also. Our electronic medical record was supposed to do everything but the dishes, and I think it probably could, but how hard is it to teach caregivers to find the information they need and to use it to create information to document well? We're at our point now, we are able to retrieve data. We have a lot of good data within Epic, so it's data that can be used. But I feel the pain with frontline caregivers who who have to learn all these systems and do it the right way, and then they have to they refer to it in terms of clicks. How many clicks is it going to be? And it's very frustrating, and the commitment to good documentation didn't get cured with electronic medical records. So when we were writing in medical records and had poor documentation and poor handwriting, it did cure the poor handwriting, but what it created was a lot of cut and paste information that is, not good information. So again, it kind of goes back to what the source is, in my view, and the ease of the technology.
Yeah, for us, just like all of you, it's perpetual optimization. You keep hearing, we're optimizing. We always are. It does help get things together, and for the first time, we have actually opened up our portals. You know how we have other partners, such as public health, FQHCs being able to portal in, but we also started to very carefully open the door with a lot of legal guidance, as you can imagine, to non-health care, but people that are vital to a care plan. So a couple of other agencies that are out there very carefully selected as well. Because it is the only thing, even though good or bad, it is the one thing that can bring our care plans together. So technology is helpful. When it comes to telehealth, it's been helpful in the right settings, the right people, the right this. It has to be the right time, right place for right things. I also want to put a plea out there, because within our own health system, and we've got the most wired, tech kind of, accolades out there and such, it is so easy to continue to be thinking you have to always be high tech. Never forget the simple. And so much of my work is going back down to just the person that's sitting there right before you. Developing that relationship technology cannot replace a relationship that you build with somebody. And you have to be able to get to that level to have the open conversation, to be able to develop care plans that make sense, for people that are seeking help and support from you. So please never forget the simple. Innovation does not mean technology. It's one form of innovation. Sometimes it's just putting two simple resources together, but it's not always big and it's not always fancy, but sometimes it's the most simple that's before your eyes.
Just want to update, we have a couple folks weighing in on this technology topic, and then there's a couple other questions from folks I've seen already, so thanks for your participation.
Good morning, I'm Glenn Roebuck. I'm with Genesis Health System in Davenport, Iowa. We serve a bi-state, 17-county area and an integrated health system there. First of all, I love your comment that, and I had written it here and you beat me to it, that innovation is not technology. Shameless plug, I'm speaking tomorrow morning on some partnerships, and that's exactly part of the piece. You can be very, very innovative without adding more technology. I think one of the challenges we had in rolling out EMRs, and many of us have had them now for 10 plus years, is that we never addressed on the front end the cultural challenges of doing this. And I don't think we had the foresight at the time to recognize that. We still run into various sectors within healthcare that have competing priorities. They look at access as a burden. They look at, it's not about providing better care for the patient, but how does this affect me financially? And those are all different plates we have to balance. We can't ignore that, but we haven't addressed those issues well. And I was just commenting with a colleague earlier, the EMR organizations may be the next pharmacies from a cost management perspective in healthcare, that the costs that we incur to simply manage our EMR systems are huge burdens, and at the end of the day, if you look at a return on investment, we're not there yet. And I think as an industry, we have an opportunity to really leverage that in our conversations with our EMR vendors who really need to come to the table differently.
Hi, I'm Janice, and I am a manager of pub health care management at St. Luke's Health System in Kansas City. Go Chiefs. Sorry, I can't help it. So we too are on Epic, and I must say that, so I like Epic, not obviously, but I think that it's something that we always have to keep in mind, and my organization hasn't always been in line with this, is that really you need to make Epic work for you, or whatever EMR you're on. So we've undergone some management structuring, and the new structure is, and we're really pushing our IT partners who are probably cringe when they see our emails come across, but we really are pushing them out of their comfort zone to say, no, we need to do more. We need you to come to the table with more. And I have to say that it's been extremely successful. We've kind of realigned what the care coordination's dashboard looks like. We've realigned what their documentation looks like. So I think that that's something that you have to remember, is that you don't necessarily have to settle. Like, push them for more. We did, and it's working. So,
One more tech question, and then I'll get to the folks who have been very patiently waiting. Thank you. Okay. I'm going to head on up here.
Oh, okay, it's a question, not a tech question. But good morning. My name is Tracy Richardson. I am the Director of Transition Programs for the South Carolina Department of Mental Health. And so what I wanted to say, and I've been listening the last 2 days, is that what the Department of Mental Health is doing and what we're doing, we have transition specialists, and under that umbrella of transition specialists, we also have care coordinators. But the transition specialists actually work with the inpatient psychiatric hospitals, the state psychiatric hospitals, with assisting with getting those patients streamlined out into the community. So we have a warm handoff with community providers. What's important about that is that, number one, the patients that are referred to us are in GRI, which is not guilty by reason of insanity. They may be incompetent to stand trial. They may have been in the hospital anywhere from the longest patient, 15 years. The average, we've discharged successfully. We've assisted with discharging successfully 50 patients. The program just started 7 months ago, which I'm happy about because I got promoted. So God is good. Okay, but the program started 7 months ago, and with those 50 discharges, the average length of stay for those patients were 2 years, and we only had a 4% return rate back to the psychiatric hospital because our transition specialists and our care coordinators looked at working with the hospitals on, we know their psychiatric issues, their medical issues, their psychosocial issues. We address all of those and make sure that they're wrapped in services prior to discharge. Their cases are open with the mental health centers before discharge. We follow them. The transition team follows them 30 days after discharge. In some cases, we follow 60 days. We'll follow more depending on the patient and what's going on with them to just make sure that they are able to maintain in the community. And I did want to say that primarily the individuals that we're working with, their diagnosis is schizophrenia, schizoaffective. We have referred several to employment programs where they're working. A lot of our patients end up in the residential care facilities, but we have about 10 to 15% that were able to go somewhere other than a residential care facility. So it's a new program. It is working. I'm very proud of it, and it's probably because of my leadership. Thank you.
I think that's awesome. We do have some limited agencies that are within our hospital, and I will say the ones that are, it is priceless. And I think that's a fantastic model that you have in place. And like I said, in the limited forms that we have one health plan, we have a senior service, and then a couple of others. It's priceless. So.
Yeah, patients can no longer be treated in these silos where we're treating them on the psychiatric unit 1 week and then the medical unit the next week, and no one talking in the community. Again, the privacy laws that we are all aware of and which were detailed this morning have always been a barrier, but I'm happy to hear that the government's waking up to that, because we can't treat people in separate entities that way.
I didn't mention it, but we also are utilizing peer support specialists as well.
That is excellent, yeah.
Yeah, just
Community health workers.
Yeah.
Mm-hmm.
Just feeding off, she mentioned peer support for those who were unable to catch that.
Well, that was what I was going to mention too. I'm Meredith Comer. I work with VIA Health in North Carolina, Asheville, North Carolina. Foodie Nation. No, I'm just kidding. Anyway, it's a behavioral health managed care organization, and we do have transition care coordinators embedded in hospitals and who do warm handoffs to community care coordinators. But one of the things that has been huge in terms of engagement has been peer support specialists. Engaging while they're on the units and then out into the community and getting them to their appointments, meeting them where they are. And so I wanted to talk or hear from you all about how that's working, or is it being utilized in the healthcare, physical health realm?
I can do a little, I can start off, and if there's others, that would be great to hear from, because we're a little early on, in this particular process. Answer is, when we first started, especially with our high-intensity home visiting and such, it's really been our nurses, our social teams. It's those dyads we have working together that have been there in the hospital, helping to see people at the bedside, see people in the units, and then see them out into the community, so that transition just happens pretty seamlessly. With that being said, we've also seen and we've recognized the huge value that a community ambassador, liaison, community health worker, whatever you call, in your organization can be of great value. So in one particular program that we have, some long-term home visiting around pregnant moms and such, long-term, and they're meaning at least 2 years, moms that have now been graduating, we've hired a couple, to serve as ambassadors. So it's our first round at it, but they're helping to go out and help with outreach. And we're developing a community, just as we did for our NICU population, where we've had babies, and now generations later, they come back and put their arms around families, to say, hey, it's going to be okay. And that's what we're developing with some of our long-term home visiting. So those that graduate, we continue this relationship forever, though, to some capacity, bring back to education and such. And these liaisons, we feel are going to be integral, for saying, hey, that was me a number of years ago. This is how I help manage it as well, and to be a part of our care team. So we've just started on that pathway. We've also started to do that within our faith community health programming that we do, as we bring centering and group education and chronic disease management and education out to different faith-based communities. It's also engaging people that are within each congregation, to help in that realm as well. But we've been a little bit limited, but starting on the pathway. But I would love to hear from others that have more mature models.
Could just as a time check, we have about 10 minutes left, so I'm going to try to get to as many folks as I can in the next 10 minutes. Thank you.
Yeah.
Thank you. Good morning. I'm Belinda Brown-Tizera, and I'm the Associate Director for Patient Care Services and Nurse Executive at the Detroit VA. And I'm just, this is really stimulating conversation. We do have a little bit of a niche of a population that we care for, but many of our veterans have the very same issues that the general communities have. But I'm just curious to know what experience you all have with the implementation of Care Partner Program for self-care management. Peer support has been wonderful. We have implemented that probably over the past 8 to 10 years, and it's really proven to be a great benefit to our veterans. But the Care Partner is a new program that we're implementing, and there are some sticky wickies around that with regard to confidentiality and patient records, but can really be a great tool to help the patient navigate through life once they are home, and once someone is no longer coming into their home, and once they're coming for their primary care visits, and to possibly keep them out of the hospital. I'm just curious. Thank you.
Well, I can speak to the Cleveland VA because we partner with them. We share many of the same patients, and they have a wonderful program. I can't give you all the details, but you could reach out to them. They have had primary care case managers going out to the homes for a number of years, and they shepherd the patient, back to where they need to be. They bring care into the home, and if their patients land in one of our hospitals, we have, we reach out to them, they reach out to us. The care, if their VA is their primary care provider, we, in our system, understand all the care has to be provided through the VA. it did take a long, again, talking about integrating systems, it did take a long time to get to that, but, because no one wanted to really talk with each other, but now there is open communication. And we have peer support for our patients with opioid use disorder. In our EDs, and several of our EDs, we have partnered with a organization, a grant-based organization. And then we just started it in November for our patients with endocarditis, who are primarily in our main campus, and also have opioid use disorder. So again, to treat the whole patient. And that peer support, like everyone has said, has really been valuable.
Good morning. I'm Sherry Latimer. I'm the Executive Director for the National Transitions of Care. And in full transparency, Mary and I have known each other for a long time, and I'm directing this question to her. Mary, many of us that are implementing these care teams and adapting them into the community often struggle with preconceived ideas from our professional licensed clinicians about working with non-licensed community health workers. And you've done a great job in being able to break down that barrier. I wonder if you might share just a few of those lessons learned from the programs you've put in place.
Well, I am the immediate past president of the Case Management Society of America, and had worked with Sherry in that capacity, where we defined what a case manager is, so that they did need to be a licensed professional healthcare individual. However, a licensed professional healthcare provider can't do everything, and they would only be able to have a very small population to serve if they tried to do everything. So we firmly believe in, this is true in my work environment too, we firmly believe in having support individuals who are not licensed doing a lot of the work that we used to do in the past. So the phone calls, the waiting on hold, pre-certing medication for Medicaid, arranging transportation, arranging referrals to skilled nursing facilities or acute rehab. So where the division falls is if we have this non-licensed person doing, the phone calls and coordinating the rides, but making a referral to a skilled nursing facility, it's the licensed provider who must provide the information to the skilled nursing facility. Or the licensed provider must tell the non-licensed person what kind of transportation is needed. Can they go in an ambulette, or do they need an ambulance? So it requires a lot of trust on the part back and forth, but ultimately that hierarchy where the licensed person delegates to the non-licensed, and he or she is responsible for what the work they do and supervising it. But it does take a team, and a team takes a little while to build too. I don't know if anyone else has examples of that in there.
Hi, I'm Dina Spear. I work at St. Mary's Hospital for Children in Queens, New York. I am the clinical care coordinator and a nurse practitioner. What you're saying is exactly why my job was created. I am a pediatric nurse practitioner. We are a skilled nursing facility for children only. We have everything from traumatic brain injury to outpatient care to long-term care. And St. Mary's has been around for over 70 years, and it used to be that there were non-clinicians doing all the referrals and gathering all the information, and these families would go home and they would be missing their suction equipment, or they would be missing the specific HME catheter, or every little detail was not being watched. So they created my position as an NP to be able to coordinate everything. So it's something that I know more and more hospitals in the New York area are doing. Some of them are doing it with RNs, some of them are doing it with NPs or PAs. But when I'm not there now and I'm here, we have a team of 4 social workers, and a PA and an NP trying to do my job. It says something, and I have to say I'm very grateful for the team that I have around me who I can coordinate the care with, but if I wasn't clinical, I would not be able to do what I do.
I agree.
All right, we have time for maybe a couple more questions, then I want to let our panelists offer some closing thoughts.
I didn't have a question. I want to comment with the peer support. With the peer support program, we do make a peer support and link all patients to peer support as they're transitioning to the community. And the other thing is that the peer support specialists, they take the time to handwrite. We have care cards, and once they're discharged, they get a handwritten care card in the mail from the peer support to say, good job on being discharged, hope everything's going well. If you need anything, please contact us back. And those care cards also have on the front of them patient art that has been done internally, just to show that we want them to succeed, and if they have any issues, don't go to the emergency room, call us.
Thank you. I wanted to give our panelists, since we have 2 minutes left, if you have final thoughts, sort of what you're working on, what you see as what's coming next, feel free to weigh in.
All right, I'm going to put in my own plug, when it comes to community in here. We're all health systems. But take a step back and please recognize that the larger health system is always your community. You're a system within a larger system, and many of us are working always in a reactive way. Somebody hits our doors and they've had a stroke. Somebody hits our doors and they have this. And we do have to work in this totally different paradigm to really go far upstream, be those social epidemiologists, get down to the roots that help prevent, that are preventing some of this health, and prosperity, so to speak, to help, to happen. So it's really important that we do have as much early intervention. We are, going out proactively at that community level, and we are integrating, with these other entities out in the community. Otherwise, we're siloing ourselves. And there's so many more resources that are out there, and if we leverage them together, then we get things up to scale. And I can't say enough how much we have to flip these paradigms and how we have to start looking at things and reaching out to people in different ways. We have to be disrupting ourselves. And I know that you've heard disruption, but we can't be stagnant, just like other entities and sectors out there. We have to be changing with how population changes out there. And then the other one thing I do want to say out there, be really careful who you put into these roles on the front lines. We didn't talk about this here today, but you have to have the right people on those front lines. If you don't, you're not going to have that relationship and you're not going to go very far. So take the time to get the right folks, in these incredibly important positions. And thank you for letting me be here today and yak at you.
Well, I can't agree more. I mean, to me, it's kind of back to the future. One of my early jobs was public health, and I did visit patients in their homes, and I wore a little blue striped suit when I did in the summer, a navy blue suit in the winter, and carried a bag and measured babies' heads and talked to grandma about her diet and got everyone to go to the city health clinic. And I'm sure all of that has changed over the years because of the efficiencies. However, I see when as this population health models have been rolled out, I thought, this is public health 101. This is what we used to do. But we've taken it out of our nursing schools. We've taken it out of the thoughts of everyone. And now, a generation later, we really see the value. Now, were they run efficiently? Probably not. I can remember where they probably weren't at all. But now, that it is the community where the health is, and patients do have a choice. And if we're going to do this work right, it is labor intensive. We can't really get around that because efficiencies have kind of put us behind the 8 ball, I think. We became very efficient, but we weren't putting the patient in the center, and we weren't taking the time to listen to the patient. So, I think we're suffering now because of that, and I think that's, in my view, that's what we need to return to.
Yeah, the pondering statistic, I mean, think about it. If people come to us 4 times a year for 4 generously long appointments at 30 minutes a pop, we're seeing them for 0.00228% of their life. We are not causing health to happen. We can start the conversation, we can start, stop the infarction, bring a baby into the world, but it's what matters next and what people have and what they don't have to be successful out there. And that's where it's up to all of us to be out there, helping with those barriers along the way.